Hello, everyone, and welcome to Arthritis Talks, Inflammatory Arthritis, What You Need to Know. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada, and thank you so much for joining us tonight. While we've come together for this event from many different places, I would first like to acknowledge the land on which I am located on, and on which our Toronto office stands, which is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I'm grateful to have the opportunity to live with my family and work on this land. Now, with more than 100 different types of arthritis, it is a very complex disease. We know that from our many conversations with people that living with an inflammatory arthritis diagnosis can be overwhelming. And that's why we're here today, to hear from an expert and answer many of the common questions about living with and treating inflammatory arthritis. Now, before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have any trouble, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button, which is at the bottom middle of the screen, and we'll try to get to as many questions during the hour that we have together. You can also click on the chat icon in the bottom middle of the screen as well to access the chat and connect with other participants, as well as our chat moderator. And if you'd like to close that completely, if you find it distracting, just click that red X icon to close out of the window. We're also pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience. So you'll see that running along the bottom of the page. Now, many questions we received in advance followed similar themes, so we will address those first before going into a live Q&A at the end of the session. And before we get started, I also want to thank our exclusive event presenting partner, Organon, along with Pfizer, United Way Winnipeg, and our other partners for their financial support of our Arthritis Talks series. Now, with that, let's get started. And first, a very warm welcome back to today's expert, Dr. David Robinson, who is joining us from Manitoba. David was actually with us 2 years ago at a previous Arthritis Talks, where we received such wonderful feedback from our audience. And Dr. Robinson, you might want to know that as of this morning, the YouTube recording of that webinar has over 35,000 views, which is just amazing. Just shows how important the information that you're sharing is. So with that, welcome, Dr. Robinson.
Great. Thanks, Sean. So we've had a few things, and one of the ones that we started off with was what is inflammatory arthritis, and we'll try and go through some of these. I do want to point out that we've changed the talk a little bit from the one we did a couple of years ago, and there's a little bit of different information on that one. So if some of the questions that we've talked about today and how you get to this arthritis isn't in this talk, you can look back at some of the other ones as well. So what is inflammatory arthritis? Well, it's a form of arthritis that's caused by activation of your immune system. And there's varying amounts of redness. The joints are warm because of the inflammation. There's swelling, like in those two fingers that you see there, but the swelling is squishy like a grape if you put your fingers on it. And patients have morning stiffness that can sometimes last for many hours. And inflammatory arthritis, like other forms, can lead to severe joint damage, but it can often do it very rapidly within just a couple of years. And because it's your whole immune system that's affected, it can affect other organs in your body as well. What are the major forms? Well, the most common one is rheumatoid arthritis. Rheumatoid arthritis we call a systemic inflammatory autoimmune disease. So it's an autoimmune disease where your body's immune system is geared up, and instead of fighting off bacteria or infections, it's attacking your joints. But it can also attack your lungs, your skin, and your eyes. And there are autoantibodies or markers in your blood that we can follow or look at called rheumatoid factor and an anti-CCP that are commonly found. And this is a fairly common arthritis. It affects up to 1% of the population. There's another form that's hard to pronounce. It's called ankylosing spondylitis. And this really refers to inflammation within the vertebrae or the spine. It can affect the other joints as well, often the hips and the shoulders, but even smaller joints. And it often starts at a very young age, so in your teens or in your early 20s, and it's very slowly progressive. But the consequence of this one is that the you get pain and discomfort, but you also end up with ultimately fusion of the spine. So if you see the gentleman who's standing there, and if you look at the side view of him, you can see that he's a little hunched over, and that the lower back that usually has a nice curve to it is all straightened out. And it doesn't look like a very good posture. The unfortunate thing is that he's stuck in that position. So he can't straighten up anymore. And when he tries to look forward as far as he can hardly look to a level surface. The bone picture that you can see there is actually a hip joint from a surgical specimen from a hip joint. And what you can see is you can see the thigh bone comes up from the bottom and it turns towards to make the ball of the hip joint. And in the socket is the other little piece. But the space between the bone and the socket is actually filled with bone. So that whole hip joint is fused solid, limiting, of course, the patient's motion. Another common form of inflammatory arthritis is psoriatic arthritis. So this is a form of arthritis that accompanies psoriasis. Psoriasis is a itchy, scaly, red skin rash that can be either very limited or very around your whole body. You can see little bits of it on the backs of the hands in this picture here and on the toe. And it can affect the joints like rheumatoid arthritis, but it can also affect the spine like ankylosing spondylitis. Typically, patients get nail changes. So you can see in the top picture, there's a fingernail and there's little, it looks like someone's taken a hammer and a nail to it, and there's little dents in it, those pitting bits, and sometimes they lift off of the nail beds. And we get something we call dactylitis, or what we often call sausage digits. So those two toes there that are big and puffy like sausages, you can compare them to the second toe in that picture, where it's a normal looking toe, but the two next to them are quite swollen. Now, as Sean said, there's 100 different types of arthritis, and a lot of them are inflammatory, but less common. And some of them are things like lupus or gout. I'm off the hook tonight because next month's webinar is on gout. And so if that's an area of interest for you, you can check in on that. We're certainly happy to answer some questions, but you can see the whole list here. On the side here, there's the arthritis types, and this is directly from the Arthritis Society website. So if we don't talk about your particular kind of arthritis, you can take a look there for some more information. It's important when we're talking about what inflammatory arthritis is to talk about what it isn't, to help separate, because sometimes people get a little confused. So the first thing that it isn't mechanical back pain. So this is what we as doctors call the most common form of back pain. And sometimes it's due to wear and tear of the spine or a slip disc or a disc injury. But it's often just the muscles that are sore. So you've been sitting in a funny chair for a while, or you lift up a package and you get a sudden pain in your back. Or you've been shoveling snow, as some people have been doing a lot of this winter. And it's usually in people who are older, unlike ankylosing spondylitis that's in young people. It's usually a sudden onset. You can tell within a day or two when it actually started. And the more you do, the worse it feels until it sort of gets better. The other thing inflammatory arthritis isn't is osteoarthritis. So osteoarthritis is the big elephant in the arthritis world. This is the wear and tear arthritis that we get. And you can see from the yellow circle down there that OA makes up, 2/3 of all the kinds of arthritis that are out there. So osteoarthritis is caused by a loss of cartilage in the joint. The cartilage is that hard rubbery stuff on the end of the bones. And as part of it, you get bony swelling or enlargement and nodules around the joints themselves, unlike that squishy grape-like fingers that we showed you before. Typical joints for osteoarthritis are your hips and knees, which is why everybody's lined up for replacements, your lower back, the thumbs right at the base of your thumb, and the very last knuckles on your fingers. Patients will have pain, like in all forms of arthritis, but the stiffness doesn't last for hours. It only lasts for a couple of minutes, 10 or 15, and you get this bony swelling. And because it's so common, more than half of the people who are over the age of 65 have some form of osteoarthritis. And yes, you can have both, but don't tell anybody in the waiting room, because all my patients will want two forms of arthritis. Now, one of the questions that came up in advance was a few people had asked about a diagnosis called inflammatory osteoarthritis. Boy, so inflammatory osteoarthritis is just kind of a bad name for a little bit more aggressive form of osteoarthritis. So osteoarthritis, although we talk about it as non-inflammatory, and we say that because we don't have any signs in the blood that the immune system is active or anything like that. But sometimes those lumpy, bony, painful joints can get a little bit red and a little bit swollen, just like with inflammation. The swelling is usually only hard and bony when you put your fingers on it. It's typically only the joints that are affected in osteoarthritis. Like I said, there's really no signs that your immune system is very active around this. And we treat it very much like osteoarthritis. There's no special treatments that we would do differently for it.
So thank you so much, Dr. Robinson. Could you share a little bit now about what some of the risk factors are for inflammatory arthritis?
Yeah, sure. That's a really good question. So this is a this is a tricky one, and I don't have a single person diagnosed in my clinic who hasn't asked, why me, why now? Um, and I'm going to show you a little bit of what I talk about to my medical students. So pay attention. There's a test later, maybe a degree in for you. I don't know. The short answer is we don't know all the risk factors and why people get these diseases, but I'm going to show you some of them. This is a model that we use for all forms of autoimmune diseases, where people have a genetic background that predisposes them to getting these. And then they have a series of exposures in their environment, and that produces some autoimmunity, which can eventually become inflammatory arthritis. Let's talk a little bit about the genetics first. So what are the genetic risks for it's complicated. It's really, really tricky. It's not like got brown hair and blue eyes and I got it from my parents. There are dozens of common gene markers that increase your risk for autoimmunity. And depending on what ethnic group you belong to, it may be different ones that put you at risk in that group. So and it may be different combinations of the gene variants between different people, even within that group, that increase the risk. So it's very common. Now, the two things that are important to know about that is that the vast majority of people who have these gene markers don't actually get disease. So it increases their risk, but most of them never get an autoimmune disease. And importantly, for those of you who have, children or siblings, we know that even though you share genetics with them, there's only a very small increased risk of inflammatory arthritis in your relatives. There are some families where it tends to cluster, but most people who have this do not have a lot of family members with this disease. What are the environmental exposures? Well, we know some of them. There's a big question mark in the middle because we don't know all of them. And there's a lot of thoughts as to what possibly there could be. One of them that we know for sure is smoking, and it's well related to all forms of inflammatory arthritis. In fact, we think that rheumatoid arthritis starts in the lungs. So you inhale the cigarette smoke and you get development of those autoantibodies that are present in the disease. We know that being overweight increases your risk of rheumatoid arthritis and psoriatic arthritis. We know that there's a good relationship between gum disease or periodontal disease and inflammatory arthritis, in particular rheumatoid arthritis. Some of the bacteria that are found in gum disease can sometimes predispose to rheumatoid arthritis. And we know that in people who have RA, when they have bad gum disease, their joints are actually worse. Now, on the right-hand side of the slide, I have something called the microbiome. And this is a really fascinating area that we're just starting to delve into. The microbiome is the term we use to describe all of the microorganisms, the bacteria and fungus and all those sorts of things in your body or on your body. So that includes all the ones in your gut, in your colon, in your mouth, on your skin, and in your genital tract. And it's well known that there are more cells in and on your body that are not human than are human. And that just makes me go ick. There's a very complicated relationship between all of these microorganisms and your immune system. And for the most part, it's a beneficial situation. So people are well and we derive some benefit from it. But we know that in patients who have inflammatory arthritis, their microbiome is different than in people who don't. And we know that when we treat people who have inflammatory arthritis, their microbiome actually comes closer to being more like those of people who don't have arthritis. And it's very interesting and exciting. We don't know how to manipulate this, and we don't really know the details as to how it works. But when we get into some of the diet risks, we can talk about that in a bit. So you have a genetic background and you have some environmental exposures, and I haven't covered all of them. There's probably lots that we don't know. And you end up with a situation where patients have what we call autoimmunity, and we can measure it in their blood, but they feel perfectly well and they have no signs of disease. And if you think about it like a bunch of kindling that's all stacked up, ready to be lit on fire, people can walk around like this for a couple of years. And I just lost my meeting. Oh, crap.
Well, we can still see you, Dr. Robinson. Don't worry.
Can you? Terrific.
Yes.
I can find my slides. So hold on a second here. I have to do double sliding. I was on auto. Yes. Okay. So do you have which slide are you got there,
Slide
Sean?
22.
Slide 22. All right. So then something happens and we come along and, oh, there we go. I got it. So something happens, an infection. It could be multiple different kinds of infections or stress or trauma or some other unknown triggers, and it lights the kindling on fire, and you develop inflammatory arthritis.
Thank you. I hope your slides are back on your screen, but don't worry.
They are. Thank you.
Okay, don't worry. We have a backup. So we have received many questions about non-pharmacological treatment options for arthritis. So could you speak a little bit to them?
Yeah, for sure. So these are really important because these are things that you can do yourself as a patient. And that includes what we're doing here tonight, which is education and learning about the arthritis. I like to tell my patients that your rheumatologist may come and go, but your arthritis is here to stay. So the more you know about it and the more you can do for yourself, the better. The Arthritis Society has a very excellent resource under support and education where some of you may have found this talk. And you can go through and look around on how to eat a healthy diet, physical activity, smoking cessation, sleep improvement, weight reduction, and so on. So these are very helpful non-pharmacologic things you can do. I want to touch a little bit on diet and exercise because they're becoming more important and we're seeing a bigger effect from these. We know that processed foods, sugar, salt, red meats are what we would talk about as pro-inflammatory. So there's actually a Arthritis Talks webinar about diet, which you can take a look at. And we know that people who substitute those for whole grains, increasing the amount of vegetables in their diet, and some people take it as far as becoming vegan or vegetarian, which has shown to help arthritis, although that's not something that's for everybody for sure. And then as well, omega-3 fatty acids. And a lot of those are in what we call the Mediterranean diet, which has been shown to help with inflammation. Exercise is the other really important bit. Exercise is important because when your joints are sore, you tend to do less and you lose muscle strength. And exercise helps maintain that. Your muscles are the shock absorbers for your skeleton. So if you lose muscle strength, you're going to increase the load that goes through the individual joints. And so by increasing your strength, you lower the load on the joint. It helps you maintain your body weight, which lowers the load on the joint. And there's some good information now that exercise can actually lower the amount of inflammation in your body through something called the vagus nerve. And so I like to use the phrase that motion is lotion. It'll make you feel better. And so get out there and move.
Great. So the next piece is an area that I'm guessing you spend a lot of your days talking about with your patients, because we know that medications play such an important role in treating inflammatory arthritis. So could you give people a sense of what types of medications are available?
Awesome. Well, we've got a couple of different groups of medications that I'll go through. The first ones are the ones that we tend to use for lots of different forms of arthritis. So these are pain relievers like acetaminophen or Tylenol, anti-inflammatories, and you know them by names like Aleve or Motrin, Advil. And then sometimes even in all forms of arthritis, we'll do some injections with some cortisone-like drugs. We don't really use cortisone anymore, but it's what people recognize. And these relieve some of the pain and inflammation. If you have ankylosing spondylitis or spinal inflammation in psoriatic arthritis, these can work well for that spinal inflammation. But importantly, in inflammatory arthritis, these drugs don't prevent joint damage. So even if you feel better with them, they're not going to prevent you from getting some of the long-term damage that can occur from these diseases. A special shout out around another group, which is corticosteroids. And these are things like cortisone, prednisone, or dipomedrol, which is given as an injection. And these can be taken by mouth or as an injection or even intravenously. And these reduce inflammation very rapidly. They're like taking a wet blanket and putting it on a campfire. They make it all better. But they have lots of side effects. And unlike a lot of other drugs where a small percentage of people will get side effects, if we give you enough of these drugs like prednisone, most people will get the side effects. And you can see that on the little bottle there, it says Satan's Tic Tacs because they make you feel better, but they're really just not good for you. And so we try to limit the use of prednisone and cortisone drugs to low doses if we're going to use them for a long time, or as a bridge to some of the safer, slower acting drugs. So those slower, safer drugs are what we call disease-modifying anti-rheumatic drugs. So they relieve the pain and inflammation so they make you feel better, but they also slow down and can even stop the joint damage from occurring. And they're safer than prednisone for long-term use, but they do take a while to work. And the common ones that your rheumatologist will give you are methotrexate, hydroxychloroquine, leflunomide, sulfasalazine, and often we use them in combination. Sometimes we might use them as a single drug. It's important to know that the earlier you start on these, the easier it is to treat inflammatory arthritis. So lots of people say, well, I'm going to wait until I have some damage and then maybe I'll go because maybe this will go away. But really what we want to do is treat it first, and we can always back off later. But if we get control of it, it's much easier to treat and we have better results. They're slow to work. They take weeks before they start to work and months to tell if they're actually going to do something. And sometimes there are side effects, like there are with most drugs. Some people can get some nausea. Some people can get some liver inflammation and low blood counts. The liver inflammation and the low blood counts are reversibles, but you won't have any symptoms to tell you that there are problems. So most need regular blood tests to be able to pick those up. And these drugs don't work for everyone. So your rheumatologist will have to do a trial and error to find the right drug or combinations for you. And they don't work on the spinal inflammation of ankylosing spondylitis for some reason. So if your main problem is ankspon in your spine, these drugs probably wouldn't be a good choice for you. The next group of drugs, which is sort of the next tier that we use, are called biologics. And these are the generic type names for a whole list of them. And you have to be careful making a list of these because there's new ones, every week. And so this list becomes outdated very quickly. But you'll recognize a fair number of these. And these are given as intravenous or subcutaneous injections, and they're big protein molecules. So as I said, these are big proteins, so they can't be taken by mouth. They have to be given as an injection. And they're very targeted to some of the key molecules that drive inflammation and inflammatory arthritis. They're expensive. They run anywhere from $20,000 to $40,000 a year, depending on your doses. And so the people who pay for medications at that level, governments and insurance companies, really limit us to using them in patients who have failed the typical disease modifying drugs that I said before. And these things are kind of brewed in like vats, like beer and stuff. You can see the vat there, and then the bacteria culture or other cultures will make the protein, which can be purified and then given to patients. There's a more recent group of drugs called JAK inhibitors as a group, and these you'll have seen some of these advertised: Xeljanz, Olumiant, Rinvoq. These are a newer group of pills, so you don't have to take them as injections. Again, they're very specifically targeted for the inflammatory pathway, and they are expensive. So again, they're reserved for those who are failing the usual DMARDs. What's a little bit different about them is there is a risk of shingles with these. So shingles is the chicken pox that hangs out in your body the whole rest of your life. And when we suppress your immune system, they can come back. And these are particularly more likely to allow shingles to come back. So we vaccinate everybody before we give these drugs. More recently, we've found that there seems to be a small increased risk of heart disease and cancer in some patients who take these medications. The risk is small, and for a while we were trying; these were going to be supplanting all the injectable things. But now I think for people who are at risk of heart disease and cancer, we tend to use them more after the injectable medications.
Okay, so we did receive a few questions about how frequently somebody with inflammatory arthritis should be seeing their rheumatologist. So could you give some guidance around that?
Yeah, for sure. So it depends. So if you are newly diagnosed as a patient and your rheumatologist puts you on a medication, it's going to take a little time for that, for us to figure out how well that medication is working. So we'll send you out the door, we'll send you back and see you in 3 months. And why do we wait 3 months? Because it's going to take 3 months to know whether that's a success or a failure. If we've changed your therapy, probably need to see you back in 3 or 4 months to see whether that's working or not. Now, if you've got established disease and you are stable on your treatment, we're going to see you much less frequently, maybe every 6 to 12 months, because you're doing well. Now, that's as long as you're doing well. It's important that communication is very important. We'll talk a little bit more about this later, but you should be calling your rheumatologist if your arthritis is flaring, if you have recurrent or serious infections, because sometimes your medications need to be held. And obviously, if Dr. Robinson gives you some methotrexate, sends you out the door, and it makes you really sick, you should call him right away and let him know that you can't take this. Don't wait for that 3-month appointment, because things can be changed over the phone or started on something else in the interim.
So we've also received some questions related to the new guidelines around alcohol consumption that made the headlines. So do these changes affect people with arthritis?
No. Yeah, so this is a big topic that came out, and I'll just give a little bit of background. So we know that people who drink or drank large amounts of alcohol can have interactions with some of the drugs, particularly methotrexate, and you can end up with liver damage and cirrhosis fairly early. Alcohol can also contribute to poor sleep and mood disorders, which are way more common in patients with inflammatory arthritis, and so large amounts are not good for people. And to be fair, we don't know, we know that large amounts aren't good, but we don't know what the safe amount of alcohol is for patients who have inflammatory arthritis and are on these medications. And that's led to the sort of running gag in rheumatology where people tell them that you can only drink as much as your rheumatologist drinks. For the record, I tell my patients they can have 1 drink per day and 2 on a special occasion. Now, in 2023, just at the beginning of this year, the Health Canada and the Canadian Centre on Substance Abuse and Addiction released new alcohol guidelines for all Canadians. And they spent a fair amount of time reviewing all of the literature around alcohol and the harms that it can cause and potential benefits. And they came up with a number of important findings. The first is that they've really found no health benefit to alcohol at all. So earlier studies that have been cited where a drink a day is good for your heart and those sorts of things, they found some serious flaws in those studies. And they really felt that the health benefits were overblown in those and that there is no health benefit to alcohol. They found that if you had 2 drinks or less per week, that carried minimal health risk. But when you have 3 to 6 drinks per week, your risk starts to rise. The risk of cancer starts to increase, particularly at that level. And if you have more than 7 drinks per week, the risk of heart disease and stroke starts to rise. And we know that people who have inflammatory arthritis already have higher risks of heart disease and stroke. So what is the safe amount in inflammatory arthritis? Well, I think we still don't know. I would suggest that if you're having more than the 7 drinks of alcohol per week, like the Health Canada guidelines, should likely aim to drink less. We know that in the 3 to 6 drinks per week, the risk is about the same as dying in a car accident as an avoidable risk. So that gives you a sense as to where to put that risk within the context of your life is.
Thank you, Dr. Robinson. And I won't ask you in the Q&A to divulge how many drinks you have per week. The next question is about another hot topic that's consumed a large share of many of our minds over the last few years, and that is around COVID-19. So what have we learned in this area with respect to COVID-19 and people living with inflammatory arthritis?
Yeah, I mean, this has been hugely disruptive for all of society, but I think for patients who have inflammatory arthritis have been particularly affected. Early on in the pandemic, when people in Europe were affected and not so much in Canada, we found out that people who had inflammatory arthritis seemed to have a higher risk of acquiring COVID and having a bad outcome from it. We subsequently learned that the risk of a more severe infection is often tied to age, being overweight or obese, diabetes, presence of lung disease, which is not uncommon in rheumatoid arthritis, and some very specific drugs that we use for inflammatory arthritis. Most of them did increase the risk, but some in particular were particularly bad. So prednisone, rituximab, sulfasalazine, and a drug called mycophenolate that we use for lupus and for sometimes the lung disease in rheumatoid arthritis. We also know that COVID can sometimes trigger inflammatory arthritis. It can be that match that lights the kindling that I showed you earlier, or cause a flare of inflammatory arthritis if you've already got it. And so what we now know 3 years out is that people with inflammatory arthritis got this message, and they were very good at keeping their masks on and washing their hands and staying away from sick people. And so they've been staying home. And when we look at blood samples from patients who have rheumatoid arthritis and we compare them to the general population, overall, there's less COVID-19 infection in patients who have rheumatoid arthritis and other inflammatory arthritis than there is in the general population. But that's come at a cost. So because you've been staying home, people have been exercising less. They have higher rates of social isolation and higher rates of mental health problems related to all that. It's been a very stressful and difficult 3 years, to be sure. So couple of words about vaccination, which is important. So first of all, what to do if you're COVID positive now. We know that most inflammatory arthritis patients will qualify for specific treatment directed against the COVID virus. They all work better if you're given them within the first week of treatment. So if you do get COVID and you're positive, you should contact your rheumatologist, your family doctor, or your local health links in order to get started on some treatment, because it will help to shorten your duration of treatment and severity of the illness. Um, Vaccination, we know, is effective to prevent hospitalization and death. It won't necessarily stop you from getting COVID, but it is important. Most of the patients in the hospital now are unvaccinated. Some drugs that we use in rheumatoid arthritis reduce the response to vaccine, but it seems like we can overcome that if we repeatedly vaccinate you. So we know that after 3 or 4 doses, the levels of protection are similar to people who aren't on those drugs. We also know that sometimes the vaccination can flare your arthritis. Most of the time, that's a mild flare and doesn't require any specific treatment. But overall, the risks of getting COVID are much higher than the risks of the vaccination for patients with arthritis. How many doses do I need? Because this seems like every time you turn around, somebody wants to give you another shot. Um, this is hot off the press. The National Advisory Committee on Immunization just last week recommended a spring booster dose for immune compromised patients. That's people with inflammatory arthritis for most of them, as long as it's been more than 6 months after your last dose. We also know that if you haven't had a bivalent vaccine, that's the newer one that's a little bit more effective, you should probably get it. So if you got your first 2 or 3, but you didn't get the fancier one in the fall, you should really consider getting one, because it has better protection for the newer variants that are out there. There is one silver lining to COVID, and that is that it really opened our eyes to the value of virtual care and telehealth. And now in inflammatory arthritis, sometimes your rheumatologist really does need to, get his hands on you or her hands on you and squeeze your joints. But the ability to talk to your doctor on the phone or on video has been a real game changer, particularly for people who are a long, long way away from where their rheumatologist works.
So thank you for all that great information, Dr. Robinson. Before we get into some more Q&A, do you have any final thoughts or recommendations for our viewers?
Yeah, I think, particularly today, communication is key. These webinars are helpful, but nothing really replaces the individual advice that's directed towards you from your rheumatologist and targeted at your individual situation. So ask your rheumatologist or your family doctor the questions that you need answers to. Write down those questions before your appointment so you have them with you, because sometimes you get in the room and you forget them all and then you don't know. And don't be afraid to ask them. I only know a couple of rheumatologists who bite.
Okay, good to know. All right, so not surprisingly, we have received a number of questions this evening, so I'm just going to get started if that's okay. The first question here is a little bit more information about how you diagnose inflammatory arthritis. So you've talked about blood markers and blood tests. Could you just give people a little bit more information about what kinds of tests do you do? What are you looking for in the blood?
Right. So the testing that we do for this, in particular, if we suspect it, the first thing that we start with is a good history, looking for those symptoms and signs that would be present in inflammatory arthritis and help us distinguish it from wear and tear arthritis. The second thing is a good physical exam. We're looking for that soft tissue swelling. We're looking at what joints are involved and what kind of changes, and then what things besides the joints are present. So if you have psoriasis, that's always a helpful marker to make a diagnosis of psoriatic arthritis. And then we check your blood. So if we suspect you have inflammatory arthritis, that's where we're going to go next. We'll look for a rheumatoid factor, which is one of the antibodies. We'll look for an anti-CCP antibody, which is another of the markers. We'll look for an anti-nuclear antibody, or an ANA, which is the marker for lupus and lupus-like conditions. And then we're going to look to see whether you have signs of inflammation in your blood. So an ESR is also called a sedimentation rate, or a C-reactive protein or CRP. And these are things that go up when you have inflammation. So if you have a cold or a flu or even a cancer, those things go up. But if you have inflammatory arthritis, they're also up. If they're normal, they're reassuring.
Okay, so building on that, and this is coming from someone who thinks they might have early stage arthritis, is it possible for your blood test to be negative and still find out later that you have inflammatory arthritis?
Yeah. So there are people who have inflammatory arthritis who don't have those markers in the blood, the antibodies that I talked about. Um, Usually they will have some degree of inflammation. When we see people in our clinics and we make a diagnosis on the first visit, I always tell them that this is a bit of a working diagnosis. We put it in parentheses because sometimes things change and evolve over time. And when we see them back in 3 months or so, they may have developed another feature that helps us modify that diagnosis. Sometimes we can be pretty clear that early on that this is really just, it's osteoarthritis, and it doesn't require further workup or following along. Their family doctor can follow it. But if there's a concern, then we sometimes will watch them carefully and keep an open mind.
Okay. You did talk earlier about the genes that were involved in some families with inflammatory forms of arthritis. Is it routine to test for those as you're diagnosing a new patient?
Yeah, good question. So in probably the only case where that's true is in the case of ankylosing spondylitis. So there's a gene called HLA-B27 that has a disproportionate weight in that setting. And sometimes because ankylosing spondylitis takes a long time to show up on X-rays and to do those things, some rheumatologists will test that gene if they think the patient has ankylosing spondylitis. So if they have signs of inflammatory arthritis or symptoms of inflammatory arthritis, they might do that genetic test to help put a little bit more weight on the scale to say maybe this is what you have. It won't make the diagnosis. It won't stop the diagnosis from being made because it's not everybody has that gene, and not everybody who has that gene has that diagnosis. But that would be the one. For the other genes, we really only do them in the context of research trials and research studies.
Okay. There's a good question here about what is the difference between biosimilars and biologics?
Yeah, that's a really good question. So the biologics have been around for us. Remember, these are the big protein molecules that they make in a vat, and they've been around for 20 years. And so they've lost their patent, and they've become what we would usually for medications call a generic. Now, when you have a small pill like Advil, for example, that becomes generic, the drug companies, when they want to make a generic version, all they have to do is show that it goes into your blood the same way as the other one, and it gets cleared from your blood the same way as the other one. And we make the assumption that it works, and almost always that's true. It does work quite well. With the biosimilars, the protein sequence is the same in the generics. So other companies that want to make a generic Enbrel, for example, can put that molecule together and they put it into a vat. But the soup that they grow this in is a secret. Okay. And so it may be different in the generic companies. And as these protein molecules are made, they're not just a protein, but there are extra little things stuck on them, like carbohydrates and other little things that we call decorate them, and they can affect the function. So when they make a biosimilar, the companies actually have to prove that it works in at least one of the diseases. So they do a clinical trial to show that it works as well as the other drug, and most of them do. And so that's the difference between a biologic and a biosimilar, and why we don't use the word generic on them. But an etanercept is an etanercept protein, depending on no matter which kind you've got.
Okay. And following on that, would you have any concerns from a patient perspective if your rheumatologist is asking, is transitioning you to a biosimilar?
Right. Yeah. So it's a good question. So across the country now, and most of the provinces have moved to a policy where they want patients to move to a biosimilar because they're about 2/3 of the price of the other ones, and these are very expensive medications. Um, and we have a lot of data. I think BC was the first province in the country to do it. We have a lot of data from some of the European countries that did this a number of years ago when the first ones came on the market. And it's very reassuring. So everybody falls off, the effectiveness of these biologics wears off over time in a certain percentage of people. And we don't see any difference in the rate of that when we switch people to a biosimilar. So if I was to switch my patient to a biosimilar, I don't really have any concerns about it. I think it's a cost saving measure, but there's really doesn't seem to be any major complications related to it or any unexpected flares of disease.
Okay. Straightforward question here. Is it possible for rheumatoid arthritis to go into remission?
Yeah, so in the textbook, probably not, but we do see it sometimes do that. So sometimes in early disease, it will, if we treat it very aggressively and get it under control on medications, we can back off those medications, and about 5% or less of people will be able to come off of their medications without having a flare. Sometimes that can last for a few years. Sometimes it can last for much longer. The vast majority of people, however, with rheumatoid arthritis go into remission, but they need to stay on medications in order to keep them there.
Okay. You touched on this in your presentation, but there's a few questions here about what do we know about inflammatory arthritis and heart disease and cardiovascular disease and diabetes and GI, etc. So can you comment about any relationships there with respect to inflammatory forms of arthritis and some other chronic diseases that we know people are living with?
Yeah. So I'll start with cardiovascular disease. That's the big one, heart disease and stroke. And we know that inflammation plays a role in those. So if you have lots of inflammation in your body, it increases your risk of having heart disease and stroke. And interestingly, in the last couple of decades, when we've been better at treating, rheumatoid arthritis and other forms of inflammatory arthritis, we found that if we treat people well and we get them into remission, that risk actually goes down. So we can reduce that back to their baseline risk for their other diseases. Now, because uh, these inflammatory arthritises tend to accumulate with age, they tend to become more common as you get older. So do the other diseases like diabetes and heart disease and all the rest. And so they will sometimes interact. And we have to be careful when we're treating people with inflammatory arthritis that we take into account all those other diseases. And then just a final word about um, gastrointestinal diseases. So there is an inflammatory arthritis that looks very much like psoriatic arthritis that can be associated with diseases like Crohn's and colitis, which are inflammatory bowel diseases, and they often mirror the disease of the bowel.
Okay, thank you. There's a couple questions here that I think are related to one of your specific slides. And so first question around gum disease, which you talked about. Could you just comment on whether it's cause and effect? Is it with respect to the relationship with arthritis? Is it causing arthritis, or is it actually just something that you're seeing in arthritis patients?
Yeah, it's a really good question. And a subject of great debate at all of the arthritis meetings. So there are people who believe that the bacteria that are associated with gum disease um, stimulate the production of the anti-CCP antibodies. And so that those are partly where you develop your immune response to them. Just like, smoking does it in the lungs, gum disease does it in the mouth. There's some controversy around that as to whether it's cause and effect. What we know for certain is that if your gum disease is active, your joints are often more active. This is much older data before we had really good treatments, and that fixing your gum disease sometimes fixes your joints to some degree, or makes them better. It doesn't stop it, but it makes it better.
Okay, so similarly, you talked about smoking for a second. Do we know anything about secondhand smoke and impact on inflammatory arthritis?
Mm, there's a little bit of data on secondhand smoke, and there's a little bit of data on pollution in general. So uh, we know that people who live next to freeways, for example, are more likely to develop rheumatoid arthritis than people who are further away from freeways. And so those kinds of environmental exposures are probably there to some degree. The effect is a little bit modest. Um, Obviously, the impact on smoking itself is based on how many pack years you've had, and there's a dose relationship to that. And so secondhand smoke, depending on how much secondhand smoke you have exposure, could possibly be a risk factor for that, sure.
Okay. This question is about a topic that we know many people come to arthritis.ca to get more information about. The question is fibromyalgia a form of arthritis?
Yeah. So fibromyalgia is a very interesting condition, and it's really typified by widespread pain, significant fatigue, um, and um, what's interesting is that when we examine patients, we can't find very much abnormal. So they don't get swelling in their joints that we can identify. They often complain of swelling in their joints, but we can't identify it. They have prolonged morning stiffness, like inflammatory arthritis, but we can't really tell anything or see anything, even using MRIs and whatnot. And it's very typically related to abnormal sleep patterns and to you know other challenges that patients have. And we don't really know what causes it. We think there is a problem with how pain goes from your fingertips and your muscles and whatnot and goes to your brain. My simple explanation is that we think of pain very simply. If I poke myself with a needle, it stimulates a nerve, it goes to my spinal cord, it goes to my brain says ouch. But it doesn't really work that way. What happens is it goes from my finger to my spinal cord, and the nerves in my spinal cord, they talk about it, they think about it, and sometimes in patients who have fibromyalgia, like an amplifier, they turn up the volume. And so you get this signal that's somewhat normal, but it's going up to your brain in an amplified fashion. Now, you don't want to know everything that's going on in your body at the same time, right? You've been sitting on that chair for a while and your bum is sending signals to your brain that, boy, this is a hard chair, but you didn't think about it until I said it. And now it's all you can think about, isn't it? So there's a filter that we have, and it blocks some of those extraneous signals. And in some patients who have fibromyalgia, the amplifier is turned up, and in some people, the filter is not working well, and in other people, both of those are abnormal. And so they get a double whammy of it. So it's not really an arthritis, it's more of a pain processing problem, we think. And but it's very typical, and it's very challenging to sort through.
Okay. This one might be a too big question to answer all in one gulp, but I'll give it a shot. So the question is, her husband was diagnosed with ankylosing spondylitis 30 years ago. What has changed in the treatment of, I'll say, inflammatory arthritis in the last several decades?
Oh, yeah, when we'll measure my career out here. So when I started training, we used some of the disease-modifying drugs, the methotrexate and whatnot, very cautiously and in very small doses for a lot of people. And in and around the time of the 2000s, early 2000s, we realized that we were probably not doing people a lot of favors. So what we came across was a real shift in how we treated people to treat them very early. So immediately when they were diagnosed, and to treat them as aggressively as we could to get them into remission. So, starting somebody on a dose and having them come back and they go, yeah, I'm a little better. But now if you get a new diagnosis and we see you, we want to make sure that you're well, you're perfectly well, because we want to aim for remission in early disease, so that because it becomes easier to treat. Okay, and we don't have to keep changing things as we go, and people get less inflammation. So we've been using our older drugs better. For ankylosing spondylitis in particular, the advent of biologics has been a real game changer for this disease, because things like methotrexate don't work for the spinal disease. And so using the biologics has been very, very helpful in treating people, making their symptoms better, and possibly preventing some of that long-term damage in the spine.
Thank you. Another question here related to drugs. Are there any that are less toxic or easier on your kidneys?
Mm. Um, so there are a few drugs that are a little bit more tolerable. All drugs have side effects, of course, even water if you get too much of it. Um, and so there are some. Hydroxychloroquine tends to be a little better tolerated and less of a problem. Um, Most drugs we know have some percentage of people who will have problems from them. And we can't really predict who's going to have toxicity from some of those drugs. And so we have to, give them a little bit of a try and monitor the patients as we go along. For kidney safety, things like Advil and Aleve and the anti-inflammatories are generally not safe in kidney disease. They can make it much worse and cause problems in that regard. Some of the medications like methotrexate are cleared by your kidneys. So in mild kidney disease, we can get away with it, but in more severe kidney disease, we can't. The biologics seem to be safe in kidney disease. Um, it's really something that needs to be individualized for your per patient.
Okay. And along those same lines, do we know a lot about these anti-rheumatic drugs during pregnancy?
Yeah, well, we do actually. That we've had lots of them around for a long time, and because unfortunately, women who are of childbearing age get rheumatoid arthritis and psoriatic arthritis, and so we've used lots of them. Um, Again, we know that some of them are completely contraindicated in pregnancy. We don't want women to get pregnant on them, and if they do, we want to stop those drugs immediately, and particularly methotrexate and another drug called mycophenolate. But we know that several of them are quite safe in pregnancy. Nothing's 100% safe, but we can continue them through. So a lot of the biologics we will continue through either the first part of the pregnancy or sometimes even later in pregnancy. Some of the other disease-modifying drugs like sulfasalazine we'll use during pregnancy along with hydroxychloroquine. And again, it's a very individual um, conversation that we have to have, because lots of women don't want to be on anything when they're pregnant. But if you can't move and you can't walk because your arthritis is bad, then sometimes we have to balance that.
Perfect. I'll just end with one question. We just have a minute. I think you encouraged people earlier, if they had a diagnosis already and they were having trouble, to call Dr. Robinson, if I'm not mistaken. But the question here is, what if you don't have a diagnosis? What would be your trigger, your sign to tell you that you really need to go speak with a rheumatologist?
Hmm. I think if you have visible soft tissue swelling in the joints, so if you have swelling that you can squeeze, and in joints like your knuckles here or your wrists or your elbows, then I think seeking some medical care. There is a symptom checker on the Arthritis Society website that can sometimes help a little bit and help narrow things down as to whether you've got something. Sometimes it can't make the diagnosis, but it's not bad actually. It can help a little bit. It's a series of questions, and it'll give you a sense as to whether there's something to be concerned about.
Wonderful. Well, thank you so much for sharing your knowledge with us this evening, Dr. Robinson. We would just like to take a few moments to get the audience's feedback on today's presentation. So for those of you watching on Zoom, you should see a poll question come up with some answer options. So click the one that really reflects your thoughts. And the question is, I feel more knowledgeable and empowered after attending this webinar. We will also be sending you an evaluation form when we email the recording and the slides. So if you weren't able to access the poll question, you'll certainly have the opportunity to provide feedback then. And we really do use this survey feedback to shape our future arthritis talks. And so we really value your input, and I would encourage you to let us know what you think. Once again, we are grateful to our exclusive event presenting partner, Organon, as well as Pfizer, United Way Winnipeg, and our other partners for their financial support of this event. Keep an eye on your inbox for more information about our next arthritis talks that Dr. Robinson already mentioned, focused on gout, coming up on April 19th. This concludes Arthritis Talks, Inflammatory Arthritis, What You Need to Know. On behalf of all of us, thank you so much for joining us today, and please stay well.